everyone, and welcome. This is Michelle Zabel, and I'm the director of the TA Network, and on behalf of SAMHSA's Center for Mental Health Services, Child and Adolescent and Family Branch and the TA Network, I want to welcome you to this series and let you know how excited we are to get this going. We've been talking and planning for this for quite a few months now, and we look forward to launching this conversation both with the states, communities, and across the nation. The purpose of this series is to really identify and provide TA opportunities around the latest innovations in child and adolescent clinical services, and our goal is that this really appeals to a very broad audience. So we encourage you to include family, youth, clinicians, administrators, all interested stakeholders in your community to really gain convenient access to the latest information on best practices through this series. We have lined up a series of leading experts that can provide a multifaceted series of webinars, office hours, and consultation. And we are committed to this really being something relevant that is helpful as you're implementing your reform initiatives, your systems of care, and to ensure that on Monday we'll be reaching out to you to elicit your feedback on what you and your community are really interested in learning about related to clinical interventions in children's behavioral health. And with that, we will take that information and guide the development of future trainings and technical assistance offerings as part of this clinical series. So please, I implore you, I know you're all very, very busy, but if you could complete that feedback opportunity for us, we will absolutely use it to design what comes next. Our intent is to keep you updated through the TA Telegram, so if anyone on this webinar is not registered to receive the TA Telegram, you can let us know through the chat or email us at the University of Maryland on behalf of the TA Network, and we will get you signed up for that, and then you'll be able to keep up to date on what the upcoming programs and offerings are. So with that, I'd like to hand it over to my friend and colleague Janet Walker at Portland State Research and Training Institute. Janet is she's a lead and invaluable partner and a core partner to the TA Network, and she's going to introduce the first in our series. Janet?
Thank you, Michelle. And good morning, everybody. Actually, I guess it's good afternoon to everyone who's not on the West Coast. My name, as Michelle mentioned, I'm Janet Walker here at the Regional Research Institute at Portland State University, and we are a core partner with the TA Network. And if you saw on that first slide, our logo was one of the many logos that are kind of crowded onto that front page because we have a great group of partners. So I just wanted to let folks know just a tiny bit about what we do here at Portland State. We are home, or one of, I guess, two homes really, to the National Wraparound Initiative. Some of you may be familiar with that. Also to the Research and Training Center on Pathways to Positive Futures, which has a focus on improving outcomes for older adolescents and young adults with serious mental health conditions, and the Reclaiming Futures Project, which focuses on young people who are having trouble with drugs, alcohol, and crime. But most pertinent for today, we are also the home of the ESA Center for Excellence, which is going to be kicking off this series of webinars and calls that constitute what we're calling now the Clinical Distance Learning Series. And so it's my pleasure today to introduce my colleague here at the RRI in Portland State, Tamara Sale, who is Director of the ESA Center for Excellence. Tamara?
Great, thank you. Okay, so welcome to the first of our webinars in our Learning Exchange. Hope to have quite a bit of interaction with you all over the course of the next month or so. Our first topic is on how early psychosis intervention is different and why it matters. We will be having a follow-up call to walk through some of the additional questions and topics that people want to cover next Tuesday, September 9th at 2 o'clock Eastern, 11 o'clock Pacific. And then that will be followed by a second webinar with Dr. Ryan Melton on September 18th, focusing on the clinical tools associated with early psychosis intervention and how those facilitate recovery, and another follow-up call from there. And then the final webinar will be with Lisa Dixon from RAISE and myself and Nev talking about kind of how to get a program started in your community. And again, there will be another follow-up call after that. So lots of opportunity for interaction. Again, my name is Tamara Sale, and joining me as presenters today are Dr. Neal Falk and Dr. Nev Jones. I want to acknowledge the considerable expertise in our audience, and in particular Jean Lassiter, who's the Oregon State Young Adult Services Coordinator and continues to be a really key player in our success. I'm currently the director of the Early Assessment and Support Alliance, or EASA, Center for Excellence at Portland State University Regional Research Institute, as Janet mentioned. And I've been responsible for coordinating Oregon's early psychosis efforts since we began in January 2001. I was also a deputy principal investigator of the Oregon arm of the EDIP study, which focused on prevention and very early first episode. At a personal level, I've spent my entire career looking for what would have made a difference for my brother and family when he developed schizophrenia years ago. And I feel like I've finally found what I was looking for. Every time I interview young people and families who have been part of the program, they reinforce that we're headed in the right direction. Instead of trauma and disenfranchisement, these families are feeling supported, hopeful, and better equipped. But still, today I hear frequently about really horrible tragedies all around the country where the family has been seeking help unsuccessfully, and people keep saying that there's nothing that could be done because of commitment laws, and that's deeply frustrating to me because I know there's something we can do, and it rarely involves forcing people into care against their will. So it's a great relief to think that with the growing early psychosis movement, I'll hear fewer of those stories. And I'm convinced that our growing network of people dedicated to sharing expertise and creating a new standard of care will move our country forward far faster than we can imagine right now. So welcome, and we look forward to sharing what we've learned and learning from you. And with that, I'll turn it over to Dr. Neal Falk.
Thank you, Tamara. Again, my name is Neal Falk. Whoops, looks like we advanced a little quick there. I'm very happy to be here today, and I'm very happy that all of you are joining us as well. I hope we can give a good presentation for you, not just today, but in the two webinars coming up. I am currently the Associate Medical Director of Cascadia Behavioral Health Care, which is a large community mental health provider here in Portland and some nearby counties. As part of my role, I've been the psychiatrist for the ESA program in Multnomah County, which is the county in which Portland is. I've been working with the ESA team here for 4.5 years or so. I started in my career working primarily with people who were homeless or people with long histories of institutionalization for severe mental illness. And it's very exciting and gratifying to be sort of at the other end of the time frame, working with people who are experiencing symptoms for the first time and actually working with them, seeing them improve, and hopefully avoiding them entering the system that I was participating in early in my career. So it's very fulfilling. I also have a clinical affiliation, as you can see, with our local medical school at Oregon Health and Science University, where I'm the assistant director of our public psychiatry training program. I'll keep my introduction brief in the interest of time and turn it over to Nev.
Thanks, Neal. So again, my name is Nev Jones, and I'm a community psychologist by training, a mental health services researcher, and currently a postdoctoral fellow in medical anthropology at Stanford. My research focuses on early intervention, early psychosis, and the sociocultural determinants of recovery. Like Tamara, I want to give just a little bit of personal context. So I first experienced schizophrenia secondhand growing up with a mom who struggled with severe symptoms throughout my childhood. In spite of these issues, it took nearly a decade before she was connected with any form of psychiatric services. I often tell people that the difference between her story and mine is in no small part due to my very different experiences with early intervention. So although I encountered many of the same barriers that I think typical young people in the community tend to encounter, especially when early intervention services are not available. I eventually discovered what was at the time one of only a handful of specialized early intervention programs in the country. The message there was always one of hope, including the faith and insistence that I would eventually return to school and finish my PhD. Now a researcher, I'm well versed in the academic literature on early intervention, which includes various controversies and areas of service delivery still in need of development and evaluation. What I hope all of us can convey in this webinar, however, is also a sense of the human lives behind EIP, the stakes of providing adequate support or failing to, and above all, the difference our states and counties and agencies stand to make for tens of thousands of young people and their families and communities. With that, let me seg to an overview of what we're going to cover today. And really briefly, a note on the two acronyms that I think we'll be using throughout this webinar. EIP just refers to early intervention in psychosis. EPI is just another variant, early psychosis intervention. So particularly for audience members who are new to early intervention, we hope to convey a sense of why early intervention makes sense and is important, to introduce audience members to the growing movement of research and program development which is taking place both in the United States and around the world, to review key elements of early psychosis intervention and how these interventions look different from treatment as usual, and then to briefly introduce some resources and encourage audience members to visit them, as well as we really hope to encourage folks to give us feedback, to get in touch with us, and to participate in an ongoing learning exchange.
So to go ahead and start the presentation, just some quick background information. I think we all understand why treating psychosis and helping people with schizophrenia matters, otherwise we wouldn't be participating in these conferences. But to put this in some context, approximately 100,000 people in the U.S. every year will have a first episode of psychosis. And I'll save you all from doing the math. That works out to just a little bit shy of 300 people per day, or not people, but young adolescents and young adults who will be developing a first episode of psychosis on a daily basis. If we narrow down our focus a little bit to schizophrenia as opposed to psychosis in general, you can see, and as I'm sure many of you know, there's a huge cost associated with schizophrenia, not just to the individual, but to family, to friends, to society as a whole. For example, financially, at least one study 12 years ago, so I'm sure the numbers are greater now, there was almost $63 billion with a B dollars of cost associated with schizophrenia in 2002, and that would include not only clinical services and clinical costs, but also legal costs, medical health care costs, etc., quite a large dollar amount. As some people would imagine, the unemployment rates are fairly high for people who have been diagnosed with schizophrenia. In one study, up to 80% unemployment. There's large disability often associated with schizophrenia as well. The 8th leading cause worldwide for the age group 15 to 44. But I hope as part of our presentation today, you'll recognize that unemployment and disability are not necessarily the outcome for someone diagnosed with schizophrenia, and in fact, those outcomes might be related in part to the treatment options that are or are not available to help someone with a first episode of schizophrenia or psychosis. The life expectancy of people who are diagnosed with schizophrenia by a conservative estimate is reduced by 10 years. Some would believe up to as much as 15 years. And that may be due in part to the fact that people who have schizophrenia often are less accomplished self-advocates for their medical health, often presenting with medical problems that are more advanced. And as you can imagine, if there's a complicated treatment for medical problems, it can be very difficult for someone who has active psychotic symptoms to be adherent to that treatment regimen. There's also decreased life expectancy due to suicide and people with schizophrenia being victims of violent crime. Contrary to what the media would portray people with schizophrenia are like, people with schizophrenia are much more likely to be the victims of violence, likely due to vulnerability to predators. If you look at suicide rates, people with schizophrenia have a suicide rate lifelong on par with people diagnosed with major depressive disorder or borderline personality disorder, somewhere in the realm of 12 to 15% lifetime risk. If you look at completed suicides, as is pointed out here on the slide, 20% of suicides of people under 35 are likely related to people diagnosed with schizophrenia and often occur early after onset of symptoms. So early intervention is quite vital in driving this number down. Also, probably not a surprise to the audience, there's a large proportion of people who are homeless who have schizophrenia, and the complement is true. Many people with schizophrenia have episodes of homelessness. A recent study showing 20% of people with schizophrenia had no fixed address. And finally, one cost that happens for people who have schizophrenia, lack of access to effective care. And again, one thing I hope you get out of these webinars is there are many modalities of care that are effective for helping people who have schizophrenia or psychosis, but not everyone is able to access some of the more newly recognized effective treatment modalities.
Okay, so very briefly, I want to talk about why it matters in terms of what things normally look like for somebody developing early psychosis in a community without early intervention. We're going to go over many of these points in more detail later in the webinar, so I'm going to be very brief. So typically there are numerous barriers to entry. These can include insurance, requirements that the individual comes to the clinic or comes to services already motivated for care, and often a lack of willingness on the part of clinicians to talk to families, or legal barriers to doing so. First treatment experiences are often in an inpatient setting and may involve police contact or police referral. And once on a psychiatric ward, young people tend to be exposed to higher doses of medication, and their experiences on the ward are often involuntary and may involve restraint, seclusion, and injection. And all of that is going to contribute to, and we know from the literature does contribute to, disincentives in terms of future help seeking and treatment engagement. From a family perspective, parents are often told that their child's condition is lifelong and disabling, and immediate applications for disability benefits are encouraged. This often leads to a pretty dramatic lowering of expectations, as well as significant distress on the part of family members. Evidence-based care is not readily available, as Neal said, and this is particularly true when it comes to educational and vocational support, as well as interventions aimed at promoting community inclusion and involvement. And finally, there's a high level of discontinuity across treatment settings, so between inpatient and outpatient, and across different types of services, as well as inconsistent care. Again, now turning to the research literature, a study conducted by Cohen and colleagues in 2000 showed that early intervention that was more or less exclusively pharmacological, meaning early maintenance medications, led to high rates of symptom remission, 77% within 6 months, but really poor functional recovery. So 2/3 of those patients who were in symptomatic remission did not experience recovery in functional areas that included work and school, as well as interpersonal relationships, all of which are critical in terms of quality of life. Further, onset typically occurs during really, really critical developmental years. So typically these are a period when young people are moving towards really significant milestones in terms of individuation and independence. So they're building independent living skills, including how to take care of their own laundry, how to cook, taking on adult roles and responsibilities, often related to work, forming reciprocal adult relationships, and critically, this includes romantic and sexual relationships, experimenting with dating, going out, which again are really critical to sort of sense of self and identity development. And then even more broadly thinking about identity, young people are starting to learn and develop their sense of who they are and who they want to be in the future, where they're headed. And finally, in terms of vocational development, this is a time when young people are finishing school, finishing high school, entering college or completing college, and embarking on a longer-term career trajectory. It's often a time of big dreams and ambitions in that sense. So, looks like people are having a hard time hearing me. So maybe let me pause and let's try to address this.
While Nev is working that out, hopefully successfully, I'll continue on with the presentation. One of the things I found in working in early intervention programs is there's a lot of myths that serve as obstacles and get in the way of treatment. This can be obstacles not only for clients entering the program, but their families and oftentimes providers. For example, 20 years ago when I was in medical school, I was taught that schizophrenia was a progressive illness that led to decreased function over time, what was often called the downward drift hypothesis. Over time, we've learned that that's wrong. There are people who plateau, and there's people who improve. Many people believe that if I'm diagnosed with schizophrenia, that means I need to apply for disability right away. We've had a number of clients enter our program who were told by their diagnosing person before they came to our program, you may as well give up your dream of school, don't waste your tuition money, you'll probably never get married, have children, and apply for disability now because you won't get a job. And what a horrible, horrible message to give an 18, 19-year-old. Similarly, many people think schizophrenia is, if not progressive, it's chronic and people cannot recover. As a colleague of mine diagnosed with schizophrenia pointed out to me, quite often people with schizophrenia get better and then they don't seek any more treatment. So we as a treatment provider, a community, have a selection bias in who we're seeing diagnosed with schizophrenia. We only see the people who continue to have symptoms, sometimes severely so. But there are people who recover quite well. Some argue or believe that treatment for schizophrenia is not effective, and while there's no cure for schizophrenia, certainly there's treatments, not just medication, but other treatments that can help improve quality of life that are effective. Whenever I run into things like this, these wrong opinions, I make a comparison to a medical illness, usually diabetes. So I've just transposed the prior slide to this slide and replaced the word schizophrenia with diabetes. And I think we'd all understand that people who have diabetes have very different courses. Some do very well with minimal intervention, perhaps losing 10 or 15 pounds, and their blood sugar levels are quite well controlled. Other people make a lot of interventions, and they still have very brittle disease. I think the same could be said for schizophrenia. It depends on the person, depends on the treatment being offered, depends on adherence, and a whole bunch of other issues. So the reason I put this graphic, this upside-down map in there for those who haven't seen it before, is sometimes we, even as providers, have to change our perspective and how we're viewing what's in front of us to be more effective and to help people recover and to be more functional.
So we talk a lot in the early psychosis field about duration of untreated psychosis. One study actually found that the average duration of untreated psychosis in the United States is over 2 years. And there's been a great deal of research that's concluded that there are some significant short-term and long-term impacts of that, both in terms of symptoms, rates of remission, and also general quality of life issues.
So picking up on what Tamara just said, I want to try to cover some of the socio-environmental factors that are actually responsible for ultimately why it is that DUP can have such an impact on long-term outcomes. So if you think about the consequences of developing active psychosis without treatment or engagement, I think it is pretty common sense that there is going to be the potential for significant disruptions at the level of existing social networks. That can include family members, that can include peers and friends in a school or work setting. Status or standing of the young person in school or employment can be dramatically affected if they come into a work setting talking to themselves out loud or talking to voices, that can very rapidly lead to a number of undesirable consequences. And then it directly affects their sense of self and self-esteem. Untreated psychosis can also lead to criminal justice system involvement, involuntary traumatic early treatment experiences, as they already covered in an earlier slide, and then actions and behaviors that adversely affect employment or educational records in various ways. So now I want to review a little bit more data that attests to the impact that early intervention does have. So in this first slide, we're looking at benefits at the end of intervention. This means typically a 2-year early intervention program. And at this point, multiple systematic reviews, meta-analyses, and very rigorous RCTs attest to the value and impact of EIP. So we tend to see decreased positive and negative symptoms, increased functioning at work and school, increased quality of life and subjective well-being, a decreased need for medications, decreased relapse and hospital readmissions, increased treatment engagement, and decreased trauma secondary either to the onset of psychosis and or those early hospitalization experiences. Okay, I see that some people are still having problems hearing me. So we'll try to tackle it when I finish with these slides again. In terms of long-term benefits, the research is still evolving and is a little bit more mixed. What we do know is that shorter-term gains can potentially be maintained even over 5 years post-intervention when there are sustained lower-level support provided past the initial period of intensive services. So if a program ends after 2 years, there are still sort of scaffolding and supports in place that ease the transition into independent care or adult services. And when EIP programs successfully reduce CUP, so just having an EIP program in place doesn't automatically mean that CUP in that community is going to be reduced. That takes active outreach, which is, again, something that we're going to talk more about later in the webinar. And finally, in the domain of independent living, so living independently in the community, not in a group home setting, not with parents, is something that we see as a long-term benefit that's not even dependent on reductions of CUP or tiered lower-level supports following the intensive intervention period. In terms of cost effectiveness, a study by Neal Falcon and colleagues in 2009 argued that the decrease in annual treatment costs per individual could amount to as much as $3,400 for an early intervention program versus $9,500 for treatment as usual. And as Neal said earlier, there are additional economic impacts understood as societal costs and costs to families, which are very hard to quantify and measure, but we know are huge. Well, the lifetime earnings of an individual who develops psychosis if we're able to prevent disability and allow them to pursue a career and work and not end up entirely supported by the welfare disability system.
So again, to broaden the picture, how many people does this affect? The usual teaching, at least in the old day, was that 1% of people were diagnosed with schizophrenia, and this would be across time, across geography, etc. We're probably close with that estimate, but not quite true, and it might be that different areas have different levels of people diagnosed with schizophrenia. For example, we're a very more mobile world than we used to be, so with people moving around so much, some communities might have a slightly higher or slightly lower prevalence of schizophrenia. Estimates can vary a lot, Probably the best estimate these days is slightly less than 1%, maybe 0.7% of people have a lifetime risk for schizophrenia. If you look at the annual incidence data, it's about 10 per 100,000 for women, a little higher for men, but some will have a estimate 2, even 3 times higher than those numbers. And that's probably because when someone presents with the first episode of psychosis, it's often very difficult to say if this is the onset of a schizophrenic disorder, if the psychosis may be due to a manic episode in the context of bipolar disorder, if it could be due to a medical issue or substance use, decompensated PTSD, etc. And remember, not everyone who experiences psychosis will end up being diagnosed with schizophrenia, and some may never have another psychotic episode again. A teacher of mine likened this to looking at the frame of a movie film. You can see very clearly in that frame what's going on, but without the context of what came before and what is going to come after, it can be hard to arrive at a diagnosis except by going over time and seeing how it develops. That's part of the reason these intervention programs are years long.
So moving into another contextual field of research, there's been a great deal of research looking at the onset of schizophrenia. And what they found is that for a large percentage of people, they have a gradual rather than a kind of a acute onset. And that onset often involves significant changes to neurocognition in areas such as working memory and processing speed, significant changes to affect, social withdrawal, perceptual distortions, auditory hallucinations, kind of the beginnings of what might become delusions, but without the level of conviction. And often those experiences are very distressing to people. They know there's something wrong, and they start to seek help. So we educate people about what those early signs look like. And if you're able to identify people at an earlier stage, psychosocial treatment is especially effective, and it's much easier to engage people. Okay. There we go. Okay, so just a little more context in terms of the larger movement. The EASA program started in 2001 as a public managed care reform with 5 counties in Oregon. It evolved gradually over time. We adopted practice guidelines from Australia and then kind of adapted those over time, started our statewide expansion in 2007, and in 2013 the EASA Center for Excellence was created. And at this stage we have 32 out of our 36 counties that either have an established program or are in the process of creating one. This is trying a lot to put onto one slide, but the idea is that it is part of a much greater movement. And when we started, our teachers were the folks from Melbourne, Australia at the Early Psychosis Prevention and Intervention Center, and there had already been a great deal of research done across the world and several national initiatives already in Australia, New Zealand, and Canada. In the United States, outside of the university programs, we really had some difficulty finding peers except for the Zucker Hillside program in Long Island. The Portland Intervention and Early Referral Service, or PEER program, started right about the same time we did, and interestingly, they were a research program entirely focused on prodrome, and we were a publicly funded and foundation-funded program focused entirely on first episode. In 2004, Great Britain started its national initiative. California passed its millionaire's tax that now has funded quite a few programs around that state. And then, of course, I mentioned the EDIT study in 2007, which brought together both PEER and EASA and focused on very early first episode and psychosis risk. So they started doing first episode, and we started doing prodrome at that point. In 2007, the RAISE study was formed, which I'll mention a little bit more in a second. And then at this point, we're aware of 17 different states that have some kind of program actively going on, and 4 states, Connecticut, Ohio, Oregon, and California to some degree, that have statewide processes. And of course, the Congress now has facilitated our movement forward. So I want to mention the RAISE program explicitly because it's an extremely important resource for everyone. It had two arms. One was the early treatment program, which is a randomized controlled trial that had 17 experimental sites, including one in Oregon. It's highly manualized, and all of those materials are available to you to implement. It was designed to conform within existing mental health systems, and they added supported education and employment because that was weak in a lot of areas. One thing that was really different about it was that it was very focused on the individual intervention and trying to kind of get something going in a local clinic, and it was not really an attempt to try to identify the whole population or to change the system. The Raise Connection program, which Lisa Dixon heads up, was developed to put together guidance and implementation materials and to kind of test out the process of implementation, and that led to On Track New York, which again has quite a few really useful materials that we'll tell you more about. There was a guidance paper issued in April of 2014 from the National Institute on Mental Health that has a wonderful quote in there basically saying the evidence is so compelling that it's not a question of whether we should be implementing these programs, but how to get them implemented in communities throughout the United States. And I have a link there to the document itself, which all of you should definitely read. And of course, we also have an important change in our context around the congressional mandate, new federal block grant requirements, the parity law, and expanded insurance coverage. So all of those things are very different for you all today than they were for us a few years ago. And then I think it's also important to talk about the context of the values orientation. So Nev's going to talk about that.
Right. So I think a critical factor that has sort of shaped the form that early intervention programs have taken is the broader rise of person-centered care around the U.S. and around the world. And Oregon colleagues articulate the tenets of person-centered care as first, a reorientation from patient to personhood. Second, a reorientation in terms of what is considered valued knowledge and expertise. And third, partnership and negotiation in decision making. I'm going to make this a little bit more concrete in the next slide. So the person's priorities and goals become central in a person-centered service setting. And reciprocal learning is emphasized, meaning the individuals receiving care are also seen as having very important lessons to teach clinicians and other providers. There is a commitment to respecting the ways in which individuals choose to understand and explain their symptoms and experiences, and that is the case even when their own explanatory frameworks might conflict with what a clinician thinks is going on. Similarly, respect for individuals' own perceptions of cost and benefit, especially when that involves medication decision making. And again, critically, these principles would hold even when a clinician disagrees, maybe even strongly disagrees with what the individual wants to do. And finally, there are absolutely no conditional services, meaning therapy might be provided or rehab services might be provided only if a person is medication adherent or adhering to a treatment protocol in some other way. In parallel with this general rise in patient-centered care, the service user or consumer movement has become increasingly powerful and exerted more and more of an influence over service delivery systems. And this involvement and inclusion extends across program development, service delivery, as well as evaluation and research. If we think about this in the context of an EIP setting, this might include a young adult advisory board that is involved in potentially all the activities of a given program or initiative, client representatives on development teams, peer-led program elements, specifically young adult support groups, youth RAP, maybe youth care specialists that are involved in service delivery in some other way. And finally, direct client leadership or representation in terms of evaluation and research efforts.
So going back to a more broad approach, and then we'll narrow it down again in a minute, I want to introduce a section where we'll talk about how early intervention programs work. They can't work within a silo. They have to work within a system. It would be very nice if it was just a clinical treatment program, but then only, the few lucky people who are able to get into the program would benefit from the philosophy of early intervention. So part of the goal of these programs is to get other agencies in the community to recognize not only that we exist, but freely borrow from us, take some of the things that we're doing and integrate it into other parts of the system in which your program is operating. Obviously, leadership is going to be a key issue, not just in the ESA program, the early intervention program itself, but at all levels of the system at other agencies and the government supports for that system. For example, here in Oregon, and I'll go through this bullet point sort of backwards, we have multiple local providers that are running our ESA programs. We cross-communicate with each other, talk with each other. In fact, the team that I work on, which is run by Multnomah County, has involvement from 2 of the community mental health centers within the Portland area, so it's a very collaborative effort. We also have a very tight connection with our state mental health authority, as well as the PSU ESA Center for Excellence, which does a lot of the data collection and develops the fidelity models that we follow. We also have a recognition that this is a very early model that we're developing as we're using it, and things will evolve over time as we learn what works, what doesn't work, and what can work better. For people who like more visual representations of what I just said, here you go. This shows that there's multiple points at the system at which early intervention programs work, operate, and intervene. And if I were going to redesign this slide as I reviewed it this morning, I would argue that not only can the arrows go clockwise, but they should be going counterclockwise as well, and we might even be better looking at this as a web where all 5 of these entities are interacting with each other, and ESA is interacting with all of them, trying to strengthen and get that cycle of improvement going in all aspects of the system. What does ESA itself do? This could be a whole day seminar in and of itself, but we'll very quickly go over all the bullet points listed on this slide. I won't go into a lot of detail here, except to note at the bottom where it says it's a transitional approach. ESA programs as designed in Oregon are not a long-term treatment. We currently offer treatment for 2 years after entry into the program, with the idea being that we help the person recognize, accept, and work towards functional recovery, hopefully over a 2-year process, and then hand the person off to an appropriate provider at that time. I believe it's a Chinese saying that it's not how many times you fall down, it's how many times you stand up. And on our team, we talk often that our job is to help the people to stand up, get moving again on their life path, and then pass them off to someone who can help them continue on that journey. So to get into details, I'll hand it off to the next person.
Great. So we focus, again, a lot within our program, and we'd encourage you to also think in a similar fashion in your community about system change. If you don't take that focus, you'll find yourself kind of stuck within your existing restrictions in terms of access and not being able to provide what people really need. And when we first started out, we only had Medicaid funding, so we went to private foundations and sought their support and gradually built into a legislative appropriation. I have made the offer that I am willing to share copies of the grants that we submitted, and you can feel free to literally steal and plagiarize. In terms of system change, leadership, again, is really key. Having a clear vision of why you're doing what you're doing and where you're headed, and then bringing people together to problem solve, continue to work towards developing the system and changing the policies. It's really important within that to have a very clear values orientation. It needs to be strengths-focused, person-centered, and also, from the very beginning, thinking about how to equip and support young adults and family members to participate in that process. And then creating accountability around practices that are articulated, outcomes that you're measuring, and finally, really making sure that you're using approaches that are evidence-supported. I use that rather than evidence-based because there are a range of levels of evidence supporting these practices. Another really important part is the focus on community. So, if you don't have an early psychosis program, often people can go for extended periods without figuring out what's going on, not knowing where to go. When they do go to seek help, often there are a lot of barriers that they find. And sometimes mental health centers are a little reticent to publicize themselves because they're afraid they might have too many people actually coming to them. So with the early psychosis intervention, you really have to push yourself out of that mindset because the goal is to get people to you as quickly as possible, and you want as many of them as you can. So that means that you have to be doing a lot of community education, and you also have to keep working on the program development, and sometimes it means you have to expand your program. Again, our programs are proactive, so we don't have waiting lists, and unlike communities where the person has to actually seek out the services, show up, be motivated, and meet all their requirements, we expect that most people referred to us won't necessarily see the need or understand who we are, and so we have a policy where anyone can refer, we respond quickly, and we have a very flexible and proactive approach to engaging people and trying to build trust so that they will actually choose to participate in treatment.
So another difference, I think, with our ESA programs, given the systems I've worked in before, it's one of the few programs I've experienced that bridges the gap that often falls between the children's and adolescent system of care and the adult system of care. We have this sort of artificial rule that at the age, or actually on the day of someone's 18th birthday, all of a sudden they are appropriate for a different system of care, and people often fall through the crack at that time. ESA is set up to work with people for a 2-year period, no matter how old they are when they enter the program. And when they're discharged from the program, when they graduate, if they're falling in that 18, 19-year-old range, we'll try to get them to a transitional age program that also is cognizant of those issues. Another issue is we do active outreach to this community. Teens and adolescents, as you can imagine, are reluctant to seek care either through denial of something being wrong or not wanting to be stigmatized. We do outreach not only to clients and community partners to entice people to engage them into care, but also to maintain them once they've entered services. If people disappear for a while, we don't just say they're gone from the program. We try to track them down, figure out what's going on, and see if we can get them to re-engage. As it says in the point underneath that, we recognize that teenagers and adolescents, young adults, are a very mobile population. For example, right now, as school started this week in the Portland area, many of our clients that we've been doing intensive services with over the summer all of a sudden are not available for intensive services. We have to recognize that we are but one part of their life, and they have to balance how they're incorporating us into the other things that they're doing, such as work or school, etc. We have, for example, a client I saw yesterday who just returned from 3 months away visiting family overseas. We have to recognize that when that happens, we need to keep in contact with them. So we do email interventions. Once in a while we'll do Skype, although we have to keep it to non-confidential issues, just sort of making sure, are you okay? Is there any support we can give you? You can certainly do more confidential type work if you have a secure network over which to do that. We also have people who go away for the summer and might not come back for a while. Again, follow up with them. Don't just wait for them to come back. Be cognizant of the fact that teens and young adults use social media quite often, and you'll have to examine how this all works out on Facebook and Twitter, and on a more local level for us, text messaging. We found, for example, that the teens don't respond very well to phone calls to remind them of next day appointments, but when we text, the success rate in getting them to show up for the appointments went up considerably. Another thing that is somewhat unique to ESA is an empowerment focus, and I'll turn that over to someone else.
Thanks, Neal. So as this just picks up on a lot of what Neal has been talking about for the last couple of slides, but without early intervention in more usual treatment settings, the goals of treatment are often based on categorical diagnoses like schizophrenia and general assumption of pathology. And when the client in question doesn't accept their diagnosis or maybe does not want it to be described in those terms, it often gets considered a lack of insight, which is a further sign of pathology. The goal is usually stabilization rather than the individual meeting their own developmental life goals. And there's a lack of opportunity to participate in decisions both in an immediate sense and decisions about the larger service. So the client is generally playing a very, very passive role across domains rather than getting more actively involved and having more power over what happens. With early intervention, treatment goals, as we've already said many times throughout the webinar, are based on what the individual wants. And they utilize the client's own words, language, explanatory beliefs, or framework. The focus is on functioning as well as particular symptoms that the client finds distressing rather than a categorical diagnosis. So for instance, if a client is hearing voices that isn't distressed by them, maybe even finds them helpful, then that is going to be okay in a clinician's eyes, and instead they're going to focus on what that client does find difficult and what is creating a barrier for them. Okay, so moving on, I'm not going to go through all the individual points on this slide, but what I want to emphasize here is the way that often what might seem like little inconsequential details or differences can have a big impact on how different services and service delivery settings really feel more subjectively to a client. And an example would be coming into a waiting room that's very medical looking, that's very uninviting, with a bunch of older patients around, many of whom are maybe displaying obvious signs of long-term chronicity. They've developed medication side effects, such as tardive dyskinesia or involuntary motor tics. There's maybe a lack of self-care. And the difference when you look at somebody who's maybe meeting clinicians at a local coffee shop or even a state board park, or when they do come into an on-site service setting, the other clients look like them or look like their friends at school or college. So they're youth, they're young adults, and there's energy, there's hope. They're not looking at kind of an older version of themselves and feeling scared of that. And finally, clinicians in early intervention settings are often overworked and burned out because their caseloads are so high. And with a really low caseload and a lot of peer supervision that's energetic and that's cutting edge, clinicians are often going to feel a lot more hopeful. And that's going to be very immediately visible to the clients coming into the service setting. I think people pick up very quickly on a lot of body signals, nonverbal language that clinicians are putting out there. So moving on to the next slide, I also just want to reiterate that psychosis is not just a disorder. So it's not like just developing a cancerous tumor. It's affecting who an individual is, their sense of self in a lot of different ways. And this extends to their own perceptions of their value to family and society, as well as family and societal attitudes towards what their value is and what the meaning or implications of the experiences they're having are. And particularly within minority communities, there are often really rich connections between experiences that are often involved in psychosis, such as hearing voices, and different cultural and religious traditions. So again, this is something that's really important to pay attention to and respect, and also think about how, at a broader societal and cultural level, we can start to reframe these types of experiences in a way that they become more socially accepted and increase rather than decrease the value of the individual who's experienced.
So family is really central also to early psychosis programs. I talk to families in communities nationwide who are trying to get help and really isolated, overwhelmed, and sometimes when they do get services, they feel blamed. Can everyone hear me? I just want to be sure. Okay, I'm going to assume that's a yes. Thank you. Okay. We tend to treat individuals and not families, especially when they pass that kind of magic age of 18, whereas in early psychosis intervention programs, the first question we ask is, where is the family? What kind of support are they available to provide? And what kind of support do they need from us? We involve them in decision-making. We see them as incredibly important allies, and we really focus on providing evidence-based education and support to them in a way that's non-blaming and strengths-focused.
Okay. So in terms of functioning versus diagnosis, a lot of this is sort of repetition from points that we've already made. So I just want to really briefly reiterate that in traditional services, a negative prognosis often ends up being communicated, and even in more subtle ways. So, for instance, I think even among clinicians who think of themselves as very strongly recovery-oriented practitioners, there's often a disbelief there that high-level success is really possible, especially for someone who might continue to experience ongoing distressing symptoms. And this is something that I've personally encountered quite a lot. So in an optimal early intervention setting, that is not the case. Diagnostic uncertainty in terms of trajectories and change, sometimes very sudden, is expected. But clinicians throughout that nevertheless are maintaining a belief in the individual's ability to pursue their own ambition.
Another hallmark of early intervention teams that's a little different than the norm is it practices more as an intensive team model, almost akin to an assertive community treatment team, not quite to that extent though. There's not 24/7 availability of staff, though there is a crisis component built in, usually in conjunction with local crisis resources. Whoops, looks like we got ahead of ourselves there, sorry. We have frequent meetings that are shared by the whole team. For example, on my Multnomah County ESA team, we have 2, if not 3 meetings a week where we review who will be seen that day, and team members can share information to make sure everybody has the latest updates. Once a week, the entire team will meet for 2 hours and talk a little bit about every client that we're treating, again, to make sure that everyone is up to date with their information. I apologize again, it seems, no, we didn't advance, I'm sorry. On the second point on the right there, you can see an example of the multiple disciplines that would be on a team. I won't go into detail, but I will point out that peer support is one of the most excellent service additions we've had on our team. It is amazing as a clinician what I find out from our peer support specialist, what clients are willing to reveal to a peer that they're not willing to reveal to a clinician. An amazing, powerful resource. I think another unique aspect, at least for the teams I've worked with on ESA, is the ability to work with a supported employment specialist as well as an occupational therapist. As we alluded to, I believe, earlier in the presentation, ESA strives to give the person what they want to receive. We don't so much tell them this is what we think is best for you. We say, what would you like and how can we provide it? And most people of this age have academic or employment needs. So we have a Fidelity Model supported employment specialist working with us, which works more in the, if you will, place and train model of employment than train and place. That means that people might start working or going to school even with active symptoms, and we do a lot of outreach support to the client as well as to their school community or their supervisors at work to help them maintain in that environment. As it says at the bottom, we don't just have expectations that they'll participate. We actually hope and try to support them and expect them to do well.
So counseling and issues related to counseling, therapy, and case management are going to be covered in a lot more detail on the second webinar. So I'm going to skip over most of this for now. What I do want to really quickly point out is that therapists out in the community typically have no specialized training in psychosis or techniques in their toolkit to deal with specific symptoms like voices or delusion. And one thing that is very different about an EIP setting is that there's high-quality specialty training and supervision available to people, and this includes in modalities like cognitive behavioral therapy for psychosis, motivational interviewing with a psychosis-specific orientation. Even if clinicians are coming in initially without that training in their background, they're going to get it both on the ground and through continuing education. And this creates, I think, a really critical difference in terms of what the service is actually able to offer clients. Moving on to peer support and leadership, again, I think that we've covered a lot of this already. So I just want to reiterate that this is one area in terms of the existing literature where not a lot of actual research has been done. So increasingly programs are including peer support and peer leadership elements, but we don't know yet exactly what kind of impact or effect that's having other than extrapolating from general adult peer support and leadership. So this is a really exciting area, and I would really encourage people to think creatively about what's possible. I just want to read one quote really quickly from an individual involved in a youth peer support group in the UK. So this person's alias is Andy. Quote, without the group, I would be isolated. I used to think I was the only person this is happening to, that I was freakish or wrong. It helped me realize that there are other people. It normalized it and made it less inhuman. And again, I really want to emphasize that even great, clinicians with a lot of experience working with psychosis are not necessarily going to make the experience of voices or unusual beliefs feel as okay as other peers, other youth who are peers to the individual.
So I'll talk very quickly about the use of medications within early intervention programs. Please recognize that there'll be a lot more information forthcoming in the second webinar on this and many other treatment details. Essentially, on an early intervention team, you have to have a recognition that medication is not necessarily the treatment or even the cornerstone of treatment. It's but one tool that you can use. Not to say we de-emphasize medications, but just recognize that it is one of many tools in the toolbox. We don't mandate, for example, that people take medications to participate in our program. We hope they do if it's appropriate, but they don't need to. It's not a necessity. As we sort of mentioned before, it's not a global use of medicine to target psychosis, but what are the specific symptoms that are bothering the individual? Very briefly, we try to use low doses and minimal amounts of medication, in essence trying to make the medication as easy to take as possible, because the harder it is to take or the more side effects it causes, the less likely the person is to be adherent to the medication. And as we've alluded to multiple times, we don't try to tell people, here, take this medicine because we think it's good for you. We try to engage the person actively into taking some responsibility for the decision-making about what medicines are to be used, when to use them, how to use them, etc. The medicine shouldn't be used just to get rid of symptoms, but more in the vein of supporting recovery, overall recovery. Again, adherence is important, so trying to make medicines easy to take with minimal side effects is important. And we find that many people do okay on what would otherwise be considered subtherapeutic dosages of medicines. Some people can actually do quite well off medicines. And I'll talk to people quite often about coming off medicines because, not surprisingly, young adults don't like taking medications, especially ones that cognitively and physically make them feel dull and tired. What I try to remind them is when you're lowering or coming off medications, that should not create a vacuum. Something should take its place. So one of the other modalities or proven treatments for schizophrenia, be it something formal like psychotherapy, supported employment, occupational therapy, or something as simple as diet and exercise, they need to do something to replace medicine if it decreases or goes away. We also use the fact that when people go off medicines, they may relapse as a learning opportunity to point out that maybe the medicine is doing something and try to integrate that into their thinking and how to integrate that into their goal to move forward. Very quickly, these are some graphs from a study done a few years back looking at the effectiveness of medication. The graph on the left basically is looking at how many people relapsed, with relapse being defined as readmission to a hospital within a year of discharge. And as you can see, 70% of people that were given a placebo were readmitted within 1 year. The middle graph, about 25% of people relapsed if medications were used in an ideal circumstance. Real world with effectiveness models, it was only effective about 45% of the time in keeping people from relapsing. The data on the graph on the right replicates that 70 and 45% of placebo and medication effectiveness. But look what happens if you add, in this example, family psychoeducation. All of a sudden, the relapse rates plummet to 20%. So again, medicine is a good tool, but there are other tools that can augment it or even replace it if the person is lucky enough. One other quick comment about medications, a study which came out last year looking at the use of maintenance medications for people who have schizophrenia versus intermittent medications only for use when they're symptomatic. Long story short, after 2 years of treatment, it looked like the group that was on maintenance medications, daily medications, were less likely to have relapsed. But as the study progressed, and last year they came out with the 7-year data, you can see that there was a crossover in the curves on the right, and it turned out that the people who were using intermittent medications not only relapsed less often, but as the bars on the right show, they had a higher rate of functional recovery. I'm not saying that everyone should be put on intermittent medications, but there certainly is some pause to think about it for individuals.
So Neal, I think given the minimal time we have left, we can just skip this slide. So I think that's Tamara.
Yeah, sorry about that. You know, when we first started talking to our mental health centers about their programs, you know, we would ask the question about, well, what do you do when people get better and they're ready to graduate from their program? And people would say, well, they don't. We don't have any idea what you're talking about. So it's really common with people with schizophrenia for people to just assume they will need to be in care forever. We have graduation ceremonies. We have an alumni network. We have a young adult leadership council made up of people who have finished the program. And we really try to be intentional about that transition process. We also try to make ourselves available long-term for problem solving when people have left the program. I still get calls from people who graduated over a decade ago. So, you know, I think that basically, you know, we're talking about trying to return to a normal life and building a long-term network for people.
Okay, so as we're wrapping up, I really just want to provide a recap of kind of everything we've talked about, but also emphasize that these interventions are really happening across multiple levels, from the individual up to the national, and maybe we could even talk about the international. So at the individual level, and we've talked about most of this, there's medication management, therapy, physical well-being services, vocational and educational support, housing support, feedback-informed treatment, and participatory decision-making. At the family level, family psychoeducation is provided, multifamily groups, family inclusion and treatment planning, and a lot of, especially the individual and family level interventions will be covered in even more detail in the next webinar, as we've mentioned. At the community level, there's local outreach, awareness, and stigma reduction, which is really critical, a focus on the community integration of the young adult, promoting young adults with experiences of early psychosis as community leaders and collaborating with schools, colleges, employers, and faith-based organizations to make that happen. At a societal level, EIP is working to normalize the experience of psychosis and to kind of diffuse societal fears and perceptions of difference. And some of that is happening through local outreach initiatives and also just making psychosis seem like something that's less scary. And finally, at a county or state and national level, there's a major focus on policy change. That includes promoting universal access to early intervention programs so that nobody is turned away, flexibility and person-centered services, a sort of true or more robust recovery-based vision. And I think essentially EIP can serve as a model for other mental health services, in part because it is operating across all these different levels, and also because it is very strongly oriented towards change rather than transformative change, rather than smaller level incremental improvements of the status quo. So just a final statement to kind of tie everything together. We would say that ideally all aspects of early intervention should work together to support the integration of clients' experiences with their personal and cultural identities, as well as family, community, and societal inclusion and acceptance.
So,
And now,
yeah.
Sorry, I'm going to turn it over to Tamara.
Okay, talking about resources, there are all kinds of resources out there, and here's an initial list. We also had on our chat psychosisprevention.org, which is the Felton Institute is working on creating a national group. I know SAMHSA also is taking a similar kind of effort, and of course we also have the International Early Psychosis Association. So there are lots of ways for us to connect. I'm hoping that this learning exchange will also kind of generate some ongoing dialogue. So we really encourage you to visit these different resources. And to think about, what strengths you have in your community, who you can bring together. I see some networking already happening on the website, so that's great. And also think about what's still holding you back. What would you like to learn? What questions do you have? And send those to us, and we will try to delve into them in our upcoming calls and websites or webinars. And go out there and visit the websites because they are just full of material. So there's no reason to start from scratch. And with that, we'll open it up for questions. There was one, I should actually mention also that at isacommunity.org, we have a link for people to go to sign up. Also, there's another link later on this presentation. And then on isacommunity.org, we will be posting a whole range of handouts, tip sheets, and then also video links. We have a video from Kathy Savicki and Jim Russell, who were the founders of the EAST program, talking about what lessons they learned that they'd like to communicate to other communities. And then we also have some interviews that we've done with graduates of ESA and with kind of content expert clinicians. So with that, we hope that you will sign up for the upcoming webinars and calls, and we will open it up for questions. There was one question already about whether there's a directory available, and as it turns out, there are, I think, at least 2 directories. Kelly mentioned that they've created one, and we've created one as well, and we're continuing to realize that there are folks still not in the directory. So as you look at the list, please add any additional folks that we may have missed. So any other questions at this point? And just go ahead and type those in, and we'll try to answer them. Somebody had asked about grants, and we will post a template grant application for folks that you can use. The data or the information may be a little outdated because we haven't had to actually apply for a grant for quite a while. So let's see. Okay, so we have a question from Sola. What's the connection between early trauma and onset of schizophrenia, and is it high? Neal, would you like to handle that one?
This is a pretty nebulous area to my understanding. The traditional thought was that there was no connection, and Nev might be able to quote some of the literature better than I can regarding the support that there is an association between early trauma and the onset of schizophrenia. It's emerging data. Nev, would you be able to speak to that?
Yeah, so there's actually a stronger link between early childhood trauma and voices or auditory hallucinations specifically relative to delusions. There's a link to delusions as well, but it's a little bit more attenuated. It also varies by type of childhood trauma, so sexual abuse specifically involving full penetration has the highest risk in terms of later development of voices or auditory hallucinations. There definitely is a link there, but it does not sort of explain schizophrenia or various particular symptoms in a direct causal way.
So more coincidental than causal.
Well, it creates greater risk for developing schizophrenia, but it's clearly not a case where if you're abused, you're going to develop schizophrenia or you're going to hear voices. There's a lot of other factors, both socio-environmental and biogenetic, that are going to be involved in that pathway to actual onset of the disorder.
Yeah. I think we use the kind of concept of a stress vulnerability model, which is that everyone has the vulnerability to develop psychosis. It's just that some people have a higher level of vulnerability that can come from a variety of different places, whether it's genetics or trauma or a medical condition or being a recent immigrant. And so what we're trying to do is to teach people to reduce their level of risk and do things that are proactive to kind of compensate. And so the way I describe schizophrenia to people is that it's a situation in which people have to manage their vulnerability for psychosis as an ongoing condition, whereas we all have it and we might not have to think about managing it quite so much normally. So any other questions or points that people want to be sure that we make? Is everybody ready to start a program now? We'll do a quick poll. I see. I know that I recognize at least one of those names, and I happen to know that they've already started a program. So that's great. Let's see. What do you know about implementation of these types of programs in rural areas? That is a really great question. A lot of the program models, especially because they're kind of based on ACT, really expect kind of a critical mass, and it's definitely challenging to have enough time dedicated. I think that's the biggest challenge. What we've said is that for the primary lead person in your program, that they should be at least 0.2 FTE. What we found is that that's the bare minimum, and they have to have really good clinical supervision to make sure that they're staying focused on the program and continuing to do the work involved. Because the danger in rural areas is that you'll forget that you have a program because the incidence is lower. What we've been experimenting with is the idea of bringing in regional resources to try to supplement what people just can't do locally. And then also I'm thinking that the manualized materials available through RAISE may be particularly helpful to rural communities because it's really focused on a lot of individual and direct one-on-one family counseling. I see a second question there about is there a connection between street drug use and schizophrenia for youth? Neal?
Yeah, I'll tackle that one. Chicken and egg thing here. There certainly is a connection in that people who have had a first episode of psychosis often turn to street drugs as a form of self-medication, if you will. I use that term very reluctantly. I'm a firm believer that there's many things someone can do to self-treat, and street drugs are but one, so there's an independent problem mixed in there as well. So from that way, yes, there would be a connection between street drug use and schizophrenia. If we look in the other direction, this is a very controversial area, and I'm very conflicted on it myself about whether using drugs can cause schizophrenia. Certainly, as Tamara alluded to a little bit ago, it can make vulnerable people develop psychotic symptoms more frequently, more often, and more permanently than people who are less vulnerable. And if you look in the literature, what I've looked at the most is how does THC, marijuana use, affect the development of schizophrenia. And while the literature will tell you that, I'm sorry here, where use of marijuana does not cause psychotic symptoms, but it will cause people to develop psychotic symptoms earlier than they would without use. My experience with ISA is that quite often when people stop smoking, the symptoms disappear and stay away long term. The flaw in my experience, though, is ISA is only a 2-year program, and it's very possible those symptoms might come back after they graduate. Thus far, I haven't heard of that happening, though.
So, I think that's a really good plug for the for webinar 2, which will definitely talk about some of these connections to alcohol and drugs and trauma as well. I would add that methamphetamine is a particularly nasty substance and seems to have its own long-term consequences. There was another question about whether we know of any training via web or video that can be given to clergy and youth leaders. I don't know of something specific about that, but we certainly may be, there may be something out there already that someone knows about, or it might be something that we could create, because we certainly have an interest in that as well. And the training is on recognizing psychosis and differentiating it from spiritual experiences. I do know that Mary Moeller, who's going to be, who's presenting on one of the videos, has written about that explicitly and developed some written materials that I'd be happy to forward. I think you have to purchase them, and they're not in video form. But
yeah, just to jump in too, that's actually this is one of my major research interests, and I'm actively working on and developing projects that are focused on better differentiating psychosis and spiritual experiences, as well as understanding the overlap. And that's partly what my dissertation was at as well. So if anybody wants to contact me directly about that, I've actually been thinking about trying to develop more specific training materials, although I think right now there's also just a lot of ambiguity and sort of high-quality investigation hasn't been done. Oh, sorry, this is Nev. Yeah, so anybody who's interested in that particular intersection, please definitely contact me.
And I just throw in a quick plug there to reiterate that there's a lot of overlap, and I don't think there's a mutually exclusive relationship between psychosis and spiritual experience. It can quite often be both. If I had time, I'd tell you about a client who I saw yesterday who's struggling with this issue. I'll be available for the Q&A session after webinar 2, and maybe we can approach it then if people are interested.
Right.
And then specifically, just to add in terms of youth materials, there's a group in London called the Voice Collective that focuses specifically on experience of voices, so not necessarily psychosis more broadly, and they have a number of training materials. So I would encourage folks who are interested to also just Google the Voice Collective, specifically a youth organization.
Wonderful. So, yeah, we definitely have, one of the beauties of having this kind of a network is that we pass around information all the time, and within ISA, people are always developing new materials, and they're generally fully willing to share it with everybody else. And so having a similar kind of a national network, I think, is going to be really fantastic. So we've reached our time, and thank you so much, everyone, and we will look forward to talking to you next Tuesday. Take care. Okay, bye-bye.